Thank you very much. I almost seem like a misfit a little bit in all the talks that I've heard yesterday and today, but I assure you one of our goals is to ensure that health becomes environmentally sustainable as well, and we're integrating that in a lot of our projects. So today I'm going to talk about some work that we have initiated in Guyana. I am a part-time PhD candidate at the HRM with the HRM program here, as well as a program manager at Population Health Research Institute. And the work I present today was co-created with Drs. Anand, Cameron, Dubey, Harvey, Ms. Shreni Patel, Dr. Rambaran, and Dr. Singh. Most of us know non-communicable diseases, particularly cardiovascular diseases, have been identified as leading causes of death worldwide, with approximately 75% of these occurring in low and middle-income countries. This is also true for Guyana, where 35% of the premature deaths are attributed to cardiovascular diseases. In addition to cardiovascular diseases, diabetes and obesity add to the global health burden, which includes the low and middle income countries as well. Non-communicable diseases are strongly associated with lifestyle factors, especially sedentary behaviors and dietary patterns. Our experience and previous work in Guyana shows that Guyana experiences a high prevalence of chronic diseases due to the current epidemiologic transition and shift from traditional homegrown produce-based diets to the energy-dense Western diets. We also strongly believe that women can act as agents of change, especially when it comes to improving diet and lifestyle for the families. Women in most places play a pivotal role in households impacting dietary risk by controlling the household's food supply and setting food and health priorities for their children. Recognizing women as agents of change, thus, we aim to break the non-communicable disease cycle by implementing a targeted nutrition education strategy in partnership with the local stakeholders in Guyana. In addition to that, there is evidence that non-physician health workers are efficient and effective in preventing non-communicable diseases. The WHO laid out a framework for non-physician health workers, and it is shown that there is over 90% agreement with physicians in high-risk cardiovascular event classification by non-physician health workers, as well as use of pharmacotherapy. Using this framework, the HOPE-4 trial was a cluster randomized trial that was run by Population Health Research Institute and in multiple countries, and was shown using non-physician health worker intervention was shown to reduce Framingham risk score, which is a surrogate for cardiovascular risk over 10 years, reduction in systolic blood pressure, reduction in LDL cholesterol levels, improved blood pressure controls for those who had hypertension, and there was no significant safety concerns in the intervention group as compared to the control groups. Thus, we have an intervention that was tested and proven to be effective. We wanted to implement this in Guyana, but as we started our initial work in Guyana in 2018, we realized that we first needed to do a little feasibility study to be able to understand if we would be able to recruit participants, understand the research infrastructure, as well as understand how we would be able to train the non-physician health workers in the Guyanese context. We initiated our work with the Dubey Gaffur Medical Research Center in Guyana in late 2018, and we were able to recruit our 100 participants over a span of about 6 months. We intended to finish our recruitment by March, so in 4 months, but we were delayed and we needed 2 extra months to finish our recruitment. These are important lessons. We were able to adapt our protocols and how to increase recruitment and retention in our study. The results of the 12-month follow-up are currently being analyzed, but at baseline, you will see there's the blue bars, the orange bars, and the green bars. The blue bars are statin, represent statin use, the orange bars, antihypertensive medication use, and the green bars are anti-diabetic medication use. The first set of bars on the left-hand side is when we screened the participants, we saw that there were about 17% participants already on statins. And after our screening and assessment of risk factors, we initiated statins in an additional 39% of the participants. So we had a total of 56% participants were on statins at the end of our study. Similarly, for antihypertensions, we had about 57% participants were identified as needing an antihypertensive following our screening, and about 37% needing an antidiabetic. So learning from our experience in Guyana, we are proposing two projects that are going to be linked with one another, but one is specifically expanding the non-physician health worker screening program now to a cohort of about 2,000 participants in Guyana who will be screened and managed by non-physician health workers using a program based on the same protocol that we ran our feasibility study, and it will be supervised by a physician. In addition to expanding our non-physician health worker screening program, we also intend to implement a food as medicine or healthy eating program within our program, where we intend to use women as agents of change, as they are the head of the healthcare households usually, and deliver culturally relevant information on identifying and reducing the consumption of ultra-processed foods while consuming a nutritionally balanced diet that is environmentally friendly and sustainable. The non-physician health worker screening, will include all adults over the age of 18. We will be following an algorithm that will be supervised by a physician, and there will be pharmacotherapy recommendation based on their risk factors assessment. The Women as Agents of Change for Healthy Eating is a program that we are going to co-develop the curriculum with our local partners, using community engagement to co-design the intervention, which would include things like education materials, meal planning, food skills, etc. And in order to assess the effectiveness of this, we will be using the RE-AIM framework to assess the reach, effectiveness, adoption, implementation, and maintenance or sustainability of the intervention program. Specifically, we are going to work towards reducing the consumption of foods in group 4, which are classified as ultra-processed foods, which are heavily industrially processed food items with a lot of artificial additives, and often the only purpose is to enhance palatability, and this are cosmetic reasons, and these foods are often very energy dense. We will work with the local organizations and ministries of health and public health to incorporate Guyana's food-based dietary guidelines, which actually is, if you look at the bowl, this is their food bowl. It is actually very, very good, where there's lots of fruits, vegetables, pulses, grains are highlighted, and with a sliver for fats and a small sliver for animal-based proteins, which is also environmentally sustainable, because we heard at talks yesterday and otherwise that plant-based proteins have a much smaller carbon footprint than animal-based proteins do. In summary, the ultimate outcome of our project is to reduce cardiovascular disease, diabetes, and related illnesses via non-physician health worker screening and physician-supervised treatment for management of cardiovascular disease. This, in turn, we hope will reduce hospitalizations and reduce the need to leave one's community for our participants and people of Guyana to receive medical care, thus reducing the carbon footprint. In addition, we will be implementing strategies for healthy lifestyle that are also environmentally sustainable, such as walking, biking to work, school, and local markets, reducing the consumption of packaged ultra-processed foods, which have a high carbon footprint, as well as increasing the consumption of locally produced fresh fruits and vegetables, as well as plant-based protein sources, which are often more sustainable. Well, with this, I'd like to thank my team, the Dipika Medical Research Center, for supporting the feasibility study as well as for supporting us in the next phase of our research project, the Population Health Research Institute, Chanchalani Research Center, the participants of our studies, and the audience here. Thank you, everybody.